Today, our topic of discussion is fluids and electrolytes, especially in surgical patients. And this is the first part of that lecture, and the next part will be next week. So, to tell you or to start with, I must say this thing that to understand this fluid and electrolytes, you must have a good baseline knowledge, and that what we get in during studying physiology. Like there are body fluid compartments, and we must know what are they, what is intracellular fluids, what are extracellular fluids, what is the volume, what are the main anions or cations of or the main electrolytes of ICF as well as ECF. Um, Other than that, we must know what is hemostasis, how it is maintained. We must know what is acid base balance, how the lungs and the blood, the kidney, and all the things like play a role in maintaining the acid base balance in the body. Uh, Also, other than that, um, there are a few more things which are connected. For example, renin, angiotensin, aldosterone system. Then there is something called as um, antidiuretic hormone or ADH. So all the things, of course, like they play a role in maintaining the body fluids as well as maintaining the hemostasis in the body. So, okay. So my suggestion for you guys, so for to all of you like who are listening this lectures, of course, if you don't remember, if you missed that part, so you there are many books of physiology, whatever you like, you can take that. Uh, Guyton is a very good book in which all of these things are given in very good detail, and you can go through that. So let's start. These are some key points, and you can see uh, um, the proper management of fluid and electrolytes facilitates crucial hemostasis. Of course, like crucial hemostasis is very important because all the vital organs, for example, the heart, the brain, the kidneys, they they need proper perfusion to work properly. And once that perfusion cannot be maintained properly, so things can go wrong. And again, the same thing. If you read this point, what I was talking about is it's very important to know the different body fluids compartments, and how the fluid is distributed, how it is maintained, what is oncotic pressure, and all this stuff. So in Guyton, like they explain it in a very, very cool way. For example, they talk about edema. Okay, so you develop a lot of concepts while you are going through that. So then you can see alterations in the concentration of serum sodium have profound effects on cellular function due to the water shifts between the intracellular and extracellular spaces. So um, the next point is about the acid-base hemostasis, which I was talking about. There are two types: the kidney and the lungs, so respiratory and the metabolic components of acid-base hemostasis. And then the next point is about surgical patients, like most acute surgical illnesses lead to some, of course, volume loss, or there is some disturbance in uh, redistribution. So of course, whenever this is the case, so what we do is we provide some IV fluids. So now, of course, when we are choosing some IV fluids, so we must know we should not be disturbing any the concentration as well as the composition of that compartment. So that's the main thing. And see, the next second last point is about uh, what you can say. Uh, of course, like there is too much investigation available nowadays, but still, in emergencies, what we rely on is about the resuscitation, and not just like the elective surgeries, but for example, in elective surgeries or emergency surgeries, or for example, the patients who have trauma, we have to resuscitate them. The last one is like some of the surgical patients. Not every surgical patient is normal one, but they do have a lot of comorbidities like malnutrition or acute renal failure or cancer patients. So of course, like when we are dealing them, and especially when it comes to the fluid, so we must know like who is the patient who have, for example, heart failure, because if you are going to overhydrate someone who have already a failed heart, of course, maybe you are going to cause more damage rather than any good to that patient. So here, of course, I'm talking about like some of the uh, basics. Of course, I'm not going in too much detail. That's what I told you. Like you can go and you can have a revision of that. Uh, of course, our main aim is to know what are the different fluids which are available and what are the different scenarios in which we can use those fluids, as well as what are the common electrolytes and what are the common imbalances in that, and also uh, about the ABGs or HL blood gases, like what can be the common issues and how they can be solved. So, like, of course, in these two lectures, I'm going to talk about all these things. So, uh, now, almost all surgical books they talk about the body fluids. See the general section, or in the first few chapters, you will find about the body fluids, their discussion. And if you know, like in adults, we have around 60% of our body which is made up of water. So, which means like 60% of our body weight is basically due to water. And now, in an average adult young female, it's about 50% due to they have more fats. Okay, and males have more muscle mass, of course. So, of course, like there is a relation between the total body weight and total body water. Okay, so uh, basically the muscles and the solid organs have higher water content than fats in the bone. So that's one of the reasons that females they have less body weight because they have more fat. So that's why the total body weight is less. So now, if what you will see, like estimates of percentage of total body weight should be adjusted downwards approximately to 10 to 20% for obese individuals. And so it goes like this way. If you have an obese person, it means like he have less water content, like the percentage I'm talking about. But if you are looking at someone who is malnourished, so maybe his body have more water contents because he don't have fats. Okay, so this thing is important to understand. The highest percentage of total body water is in newborns. Like 80% of their body weight is basically water. So uh, that's very important thing to remember again. But like uh, you will study about this in more detail when you will go and study pediatrics, and you would know how in pediatrics fluid resuscitation works. Okay, so now this one is like they talk about the percentage of total body weight. So we divide what you can say. Uh, there is intracellular fluid and there is an extracellular fluid. So the intracellular fluid is basically the around 40% of body weight, whereas like the extracellular is around 20%, and out of that 20%, basically 5% is of plasma, whereas 15% is of interstitial fluids, right? So here they talk about a 70% male and a 60% female, and they write like how much water content they have. So anyhow, if you will just pay attention on these two values, the intracellular is around 28 liters, whereas the extracellular is about 14 liters. So uh, you can see this one, and uh, of course, like extracellular is like there is around 10.5 liters in interstitial fluid, whereas 3.5 liter is in plasma. Uh, Again, one more what you can say uh, distribution chart which is given. Okay, now different books have different charts available, and what you are going to see is like there is like some differences in value. So don't get worried about that, because maybe like you will find 42%, and here you will found 21%. So that's like this is, you can say, like of course everyone have a different body makeup, so it is, you can say, somewhat taken as an average. So the importance of showing you this thing is simply to tell you that this is the ECF and this is the ICF. So if you will see uh, in the ECF, okay, they are showing the cations. Okay, cations are like sodium, potassium, calcium, and magnesium. If you will see, like the main cation, uh, what you can say of ECF is sodium, whereas the main cation of ICF, intracellular fluid, is basically potassium. Okay, and that, if you know, like uh, this balance is maintained due to what you can say sodium potassium pump. Okay, so so the ECF, if you will see, there is sodium, which is the principal cation, uh, and they have what you can say uh, other cations as well, but they are like in less proportion. Whereas you can see like potassium makes the big chunk in the ICF. Okay, they do have magnesium, and then comes sodium, and then comes calcium, right? So again, this gradient is maintained, I told you, by sodium potassium pump, or so you can say sodium potassium ATPase pump. And remember, the proteins have negative charge, right? And they are, you can say, the anions. So these are all the cations. Again, a very helpful, you can say, uh, bar chart, you can say, this thing shows you the plasma, the interstitial fluid, or and the ICF. So basically these two are ECF and this is ICF, intracellular fluid and extracellular fluid. If you will see, like the story is somehow same between these two, right? Like the main cation, which is sodium 142 144, and the main anion, which is chloride, is like almost the same. Whereas when you will look in the ICF, uh, the main cation is potassium, and the main anions are these, right? So now what you will look like here, these are basically the important one to remember, right? So of course, like they have sodium and they have potassium, but I'm talking about the, what you can say, the largest part is made up of what. So again, like these are the basics which we are going through until now, and very important to understand, by the way, because like when you are going to study the fluids, of course, like whenever we give anyone IV fluid, so in which compartment we give, we put that fluid into the blood, in the plasma, and then there, from there, it is going to redistribute between the ICF and ECF, right? Interstitial fluid and ICF. So of course, by the process of diffusion, osmosis, like very very basic things. But of course, uh, anyone who in which like you started giving a IV injection or IV, what you can say, drip of water or sodium chloride, normal saline, for example, or dextrose 5 water or ringer lactate, you are putting in this compartment, and then it is going to redistribute. So like and why I'm stressing on these things, of course you would understand, because when you are going to study the composition of different fluids, then you would know like different fluids have different sodium levels and different potassium levels and this and that. Then comes the osmotic pressure. So osmotic pressure is basically uh, what you can say, all the electrolytes in any compartment or in any solution basically are number of particles per unit of volume, right? So that's why it is called as millimole per liter. So m mole slash liter, okay, millimole per liter. So of course, so like how many millimoles are there in 1 liter? So liter is the volume and millimoles are basically the number of the particles. And so of course, like each of the particle is have a certain charge on it. So for example, when we talk about the charge, so we can say milli equivalent per liter, right? Of course, like uh, now the important thing is not every particle which is present in the solution have what you can say some effect on that solution, or you can say osmotic effect. uh, okay, to understand this thing, what is osmosis? Osmosis, we had covered osmosis, right? So we know what is osmosis. Like osmosis is basically uh, like through a semi-permeable membrane, when the you can say the solutes are traveling from the area of lower higher concentration to the area of lower concentration. Very very basic concept, guys, like uh, because all the things of course we had done in our pre-medical studies. So now for example, if any particle is traveling from the area of higher concentration to the area of lower concentration, so what it means, it is basically osmotically active, right? So that's why just those things or those particles makes the difference, which are osmotically active, because they have some, you can say, role, they have some effect, uh, they makes a difference. So that's why when we talk about the osmotically active ions, so that's why in that case we call it as milliosmol per liter, right? So because now so millimoles per liter, like it is like how like all the particles in the solution, whereas milliosmol per liter is we are just concerned with those particles which are osmotically active, okay? So now see, actually, like just talking about these basic concepts like take a lot of time, and uh, it's good like if you will go through some basics, or if you don't understand what I'm saying, so you would understand this lecture better. Okay, so uh, now you can see over here the osmolality of the intracellular as well as the extracellular fluids is maintained between 290 and 310 milliosmol per liter, of course, okay, in each compartment. So because cell membranes are permeable to water, any change in osmotic pressure in one compartment is basically will lead to redistribution of the active osmotic pressure. For example, like what I'm saying, whenever we give any patient or anyone like resuscitation or fluids, like of course we are going to put in this compartment, right? So after the fluid will be in this compartment, then it is going to redistribute, right? Remember plasma, and then it communicate with different body tissues by the help of capillaries. What is interstitial fluid is it's basically the cells, uh, they are held together, and the spaces between the cells is all the fluid around that is interstitial fluid, and intracellular fluid is basically the fluid which is inside the cells. Okay, and we know like the cell membrane is semi-permeable membrane, and it allows the movement of different uh, particles through them, or by the help of the presence of what you can say uh, different pumps like sodium potassium pump. So now, uh, okay, so one of the thing to tell you basically, when we have to check, for example, if I have a patient and I want to check like what is the osmolality of his blood, for example. Okay, so what I will do, I cannot take fluid from the cell, I cannot take the fluid from the interstitial fluid. Of course I can take the sample from the blood, which is the plasma. Okay, and plasma being ECF, and the main cation of ECF being sodium. So whenever we calculate the plasma, the serum osmolality, this is the formula. Okay, now to give you an idea, what I'm talking about is simply, see, we have glucose in the blood, but see here, we are dividing that number by 18, which will result into very, very low number. Okay, so uh, as well as we have urea in the blood, but we are dividing that blood urea nitrogen by 2.8. So the value will be very less, right? But sodium, we are multiplying it by 2. So basically, for example, see, normally in ECF, back to this one, in the plasma, the sodium is 152. So 142. So 142 multiplied by 2 will become how much? It will become 284, which is very much close to the normal osmolality of the blood, right? Of course, 282 we get, plus we will, a little number, this one will add, and this little number, this one will add, and we will get the final reading of this one. I'm talking about the normal persons. So I just want to tell you that sodium play a very, very, very important role in determining the osmolality of the blood or of the serum. Okay, so now a few more good concepts. Uh, uh, like you will see over here. Okay, before going on this thing, I would rather want to show you something uh, very basic. Wait, oh, sorry. Wait. Okay, okay. I'm going to make what you can say a new slide. Okay, uh, and we are going to make the slide um, of this type, right? Okay. Um, for example, uh, say daily water balance. Okay. So of course, like we take some water every day, we lose a lot of water every day, right? Things make sense. Um, so we gain water, we lose water, right? So here I will write like water gain every day, and here I will write water loss every day. Okay. So of course we are talking about daily water balance. So now uh, um, we take on an average, for example, um, like 6 to 8 glasses of water, right? Let's, for example, it makes 1,500 milliliter, right? So we drink, okay? So you can say this is the oral intake, okay? We drink water. Secondly, the other thing by which we what you can say that we take water, right? Um, is basically um, what you can say. It's around. Let's, for example, it's like the range is around 400 to 700, but okay, let's make it 500 milliliter. We we take it in form of food. Okay, like of course, like the vegetables you are eating, the fruits you are eating, the meat you are eating, whatever you are eating, of course, that contain water. Um, One more thing, for example, that is, um, okay, one of the way uh, by which we can get water is in the form of okay, these all are ranges. Like a normal person basically drink 1 liter to 2.5 liter. Person can take 300 to 800 milliliter in the form of food, whereas the metabolism which is going on inside your body, it produces water as well. We call it as water of oxidation. Okay, so let's say, for example, it produces 300 milliliter of water. Of course there is a range. So metabolic processes, okay, is producing like this one. So how much it makes around 2,300 milliliter of water, like the total. Of course it's range, so it's like just for simplicity purposes I'm telling you. So the three ways by which we gain water is like this way. And what are the ways we lose water is basically, wait, undo typing. Okay, is um, one of the way is of course urination, and normally we urinate around 1.5 liters of urine, and we lose water in the stools as well, and we lose water in the form of uh, from what you can say, depending on the weather, it's humid, it's hot, it's cold, we lose it from the skin as well. So basically, 500 ml which we take in food, or 500 ml we lose. Uh, sorry, yeah, we lose in the form of lungs and skin, and we call it as insensible water loss. Okay, and another 300 ml of fluid we lose in the form of feces. Okay, so see, this is how um, the balance is maintained. Just to show you this thing, uh, and again, these are the ranges. So the water you are drinking is going in the urine. The water you are taking in the food, basically you are losing it by the mean of skin, by the mean of lungs, and the water which is produced in the metabolic processes is basically going in the form of feces. So this is also called as, this one is also called as insensible water losses. So of course, whenever in the hot weather we lose more water, in the cold weather we lose less water. Okay, so you can see over here, a healthy person consumes an average of 2500 ml per day. Approximately 1500 is from oral intake, 1000 extracted from solid fluids, and 100 200 ml from metabolism. So okay, if you will want to fix this thing, you can fix it like this way. And this one is saying, for example, make it 200. Okay, so how much it will be? It will become 2000, 500, 600, 700, right? So daily water losses include 15 ml in urine, 102 ml in stools, and 1000 as insensible water losses. So you can see, like, okay, 1000 is like called an insensible water losses, and 200 ml in feces. So that will make around 2700. So that's what I was saying, like, every book have its own way. So the main point to discuss, to remember, is like the water gain and the water loss every day remain same. Okay, and these are the routes by which we take, and these are the routes by which we lose. Of course, like in surgical patients, the story becomes a little different. For example, after surgeries, they put drains in the surgical site. So of course, like, they lose fluid from the drains as well as sometimes, like, they put a NG tube, like the nasogastric tube. So the patients lose fluid from there as well. So this is like about the daily water losses. And in fever, hypermetabolism, and hyperventilation, of course, insensible water losses will be increased. The kidneys must excrete a minimum of 400 to 800 milliliter of urine, of course, because the kidneys have to get rid of all the waste in the body, right? So the typical individual consumes 3 to 5 grams of dietary salt every day, with the balance maintained by kidneys. And sweat is hypotonic, and sweating usually results in only a small sodium loss. Okay, though the sweat is a little uh, salty in flavor, but doesn't mean like you are losing a lot of salt from the sweat. And that's the reason, of course, like when you go for exercise, and when you come back, you never drink salted water, rather you drink the normal water, and you stay fine. Okay, so that's one of the reasons. So if you understand this thing, uh, okay, let's go further. uh, okay, this slide, everything is written in too much detail, but uh, what is the important thing over here is, I'm just giving the extract of all these things, what is written. you know there are two type of things. One is sympathetic activity, one is parasympathetic activity. And whatever is there, uh, the important thing to remember is that, due to sympathetic or parasympathetic activation, the body release some fluids or some hormones, right? Of course, there are a lot of hormones like uh, cortisol, catecholamines, ACTH, aldosterone. So all these hormones which are released as a result of, uh, you can say, the sympathetic activation, or you can say these are all increased in response to fight and flight response. Now, see, any type of stress on the body. Okay, this stress is not, I'm not talking about that stress which you feel every day in your life, rather, of course, that is also stress, but surgery is a stress on body. Uh, Trauma is a stress on body. Okay, so any patient, Any surgical patient is basically under stress, and that leads to the release of all these hormones. And what happens when all these hormones are released? So the body basically perceive, or the function of all these hormones. For example, what is ADH? It is antidiuretic hormone. So this is the hormone which prevent diuresis, or which prevent urine formation, which conserve water inside the body. So the net effect of all these hormones release is what? It retains the salt and water by the kidneys. So remember, whenever any patient go for a surgery, after surgery, at least for the first 24 hours, the kidneys, they form less urine. Why? Because the body is conserving that fluid. Okay, so that leads to dilution effect. Okay, that leads to dilution effect. Like, of course, when the fluids in the body will be retained, the water will be retained, it is going to dilute the ECF, for example, right? So, see, read this line, it's very important. Sodium is also retained, but not to the same degree as water. So, sodium is also temporarily diluted. Okay, so see, and now, whenever we have to see, like, either any patient have dehydration or not, what the mothers do. Uh, when the baby, they have fever, they have diarrhea or vomiting, and they are not wetting their nappies too much, the mothers know, okay, our baby is dehydrated. So when you're well hydrated, of course, you have to pee a lot. So that's the reason. If you will keep on drinking water, you will keep on going to the for urination, right? So in the first 24 to 48 hours is the body response after surgery. I'm talking about is the body response to conserve water. Okay, so that's the reason care must be taken, and we must do investigations. Okay, or in other words, we must not overhydrate any patient just because the kidneys are not producing enough urine. Okay, so remember that this effect is dilutional effect and does not imply a need for giving more ions. Quite the opposite, in fact, since ions are already being retained by the kidneys. Okay, after the first 24 to 48 hours, the hormonal effects on the kidneys are gone, disappeared, and what happened, like uh, the body will start bringing back it to the original shape or original status. Okay, so a very important concept to remember. uh, Now, see, post-operative water balance. So what here is written is like after the surgery, right? What happens is you can say uh, obligatory water losses are around 1500 ml per 24 hours, 1000 ml insensible loss from lungs and kidneys, and 500 minimal obligatory urine loss. Okay, so these are almost 1500 per 24 hours. So sometimes these losses can be increased. Why? For example, if the patient have tachypnea or fever, so of course they will lose more water. Okay, but what will happen that the kidneys will lose less water. Why? Because of the first 24 hours, because of the effect of the hormones, they are going to conserve the water. So that's why they say like 2.5 liter per 24 hours is usually adequate fluid replacement for adults in the first 24 hours after surgery. Now, I will tell you something. I will take you back to this one. We lose this much every day. So, for example, if a patient is not taking anything by mouth, not eating anything, not drinking anything. So if someone will ask you how much fluid you must give that patient in 24 hours, so your answer should be what? This much. Okay. Why? Because they lose this much, so we must replace this one. In fever, give more. In tachypnea, give more. Okay. So as the kidneys begin to excrete more water, the amount of the fluid should be increased to 3 liters per 24 hours. Okay. And this is the baseline requirement for adults of every spectrum of size and weight. But it must be remembered that any other losses I was talking about, like nasogastric suction, add that also. So see, this is how we maintain the water balance. Because in surgical patients, especially post-operative surgical patients, we provide them with IV fluids. It's not like this, like they start eating right away. So now, I always ask this question in the class, like, what is the best way in any admitted patient to see either they are losing water or they are retaining water? They do a weigh, they weigh the patient, they weight the patient every day. They see like how much weight they are. For example, if someone who is 78 today, 78 kilograms, and tomorrow he's 79, and the day after tomorrow he's 79 9.5, so no one can become so fat and so quickly. Of course, the only thing which can make the difference is like they are retaining water. And if someone who is 78 today and tomorrow they are 77.5 and the day after tomorrow they are 77, so again no one can lose weight so much quickly. It's just the water, they are losing more and more and more water, right? So of course it's not like just this, we there are many other things which we can see. For example, uh, anyone who is retaining water, of course they can develop edema, they can develop uh, pulmonary edema. Okay. So their eyes will become puffy. Okay. Their blood pressure will become high, their pulse will become less, their skin turgor will be fine. So on the other hand, someone who is losing water and they are becoming dehydrated, they will lose weight, their blood pressure will go down, their pulse will go up, their eyes will be sunken, their skin turgor will be reduced, their capillary refilling time will be extended, things like this, right? So what will happen, for example, the most common causes of volume deficit in surgical patients is the loss of GIT fluid from nasogastric suction, vomiting, diarrhea, sorry, it's fistula, if they have any fistula, if they have burns, or if they have something like peritonitis or obstruction and things like this. So they lose a lot of water because of this thing. And whenever they have, if some patient have acute volume deficit, like they lose volume very quickly, so the signs which they will develop is cardiovascular and central nervous system signs. And anyone who is chronically losing water or they are going in chronic deficit, uh, they will give tissue signs, their skin turgor will be reduced, they will be having sunken eyes. Okay. And of course, we go for the labs and we check the osmolality of the urine, of the blood to see what's going on. So, now, uh, how these things are regulated, okay, how the body maintain hemostasis. Of course, like volume changes, whenever there is any change in volume, how the body sense these things is basically by there are osmoreceptors, there are baroreceptors in the body. Okay, uh, like osmoreceptors, basically these are the sensors which detect the osmolality. Okay, and these are the centers, which basically give, for example, when the osmolality is increasing, so it will activate your thirst center and you will feel thirsty, you will start drinking water. Or for example, if the osmolality is decreasing, so it will point the kidneys or direct the kidneys to lose more and more and more water, right? So simply when the osmolality is increased, thirst centers are activated. Okay, so and of course, like the different hormones are also released. For example, ADH will be released, antidiuretic hormone will be released, right? And baroreceptors basically sense the pressure of, you can say like these are the pressure sensors. Osmoreceptors are detect the change in osmolality. Baroreceptors sense the pressure, and they are located in the carotid arch, aortic arch, and carotid sinuses. So baroreceptors are those which are going to activate your sympathetic or parasympathetic pathways, as well as, of course, the release of different hormones like renin, angiotensin, aldosterone system, and many others. Okay, so this is how all these things are regulated, and kidneys are very important in maintaining or in defining the changes. Okay, and then comes, in the next lecture, of course, we will discuss what is hyponatremia, what is hypernatremia, what is hypokalemia, what is hyperkalemia, and we are going to discuss all these things. Okay, but again, guys, I'm making it clear. I will not go into much basics because for me, you guys had already done physiology, so you guys had should know these things, right? Okay, then comes um, I will give you a small introduction in this lecture. Okay, before going to this one, okay, this chart is very interesting. And why I'm showing you this thing, because in surgery, for example, if you put any patient on a nasogastric tube, so what is a nasogastric tube? Like it is, you are taking out secretions, the secretions which are forming in their gastric area. You are sucking them out. For example, someone who have repeated vomiting, so of course they are losing their gastric fluid continuously, right? Or for example, someone who had diarrhea, they are losing their intestinal juices continuously. Or for example, someone who have a fistula in the intestine and they are losing their secretions continuously. So see, this chart is basically talking about the juices, saliva we produce, gastric juice, bile, pancreatic juice, and intestinal juice. How much they are produced daily? 1 liter of saliva, 1.5 liter of gastric juice, 1 liter, and 1.5, 2.2 liter of intestinal juice. How much sodium they contain, how much potassium they contain, how much chloride they contain, how much bicarbonate they contain. How I remember this thing is simply by this way. As we go from mouth towards anus, okay, down, sodium will increase. Saliva have the least sodium, it keep on increasing. Intestinal juices have a lot of sodium. Opposite to chloride, saliva produces have contain a lot of potassium, whereas you can see it goes down, down, and down. Chloride have a different story. How to remember this one? Remember, gastric juice have HCl, the acid. So H plus Cl, chloride. And that's why anyone who is repeated vomiting repeatedly, they have hypokalemic, hyperchloremic. Their chlorine levels, the chloride levels goes down. Okay. And bicarbonate, if you see over here, pancreatic juice produces a lot. Okay. So these are the daily productions of body fluids and the electrolytes they contain. Someone who is losing a lot of intestinal juice every day by the help of diarrhea or fistula is basically losing a lot of sodium as well as potassium, right? And chlorides as well. So, like this way. Last for today, and then we will continue this lecture later on in the next part. This is the clinical signs which we can observe during physical examination. What we see in the patient, in the hospitals. For example, someone who is hypovolemic. Hypovolemic means what? Like lose a lot of volume of water. Or hypervolemic, like someone who had retained or gained a lot of water, fluids. So, how we check? If you see the hypovolemia, you can see intravascular means, like, of course, there will be less volume in the blood or in the plasma. So, JVP is jugular venous pulse will be decreased. Blood pressure, there will be orthostatic drop. What is orthostatic drop? If you will check the blood pressure someone laying down on the bed, and for example the blood pressure is 120/80, and you will ask the patient to stand up. Well, the patient will stand up, and if his blood pressure come back as 105/75, so there is a lot of drop in the systolic blood pressure, that is called as orthostatic drop. If you will auscultate the heart, they will be having tachycardia. Auscultation of the lungs will be normal. Skin turgor will be decreased. There will be no edema. If you will ask the urine output, it will be reduced. Body weight will be decreased. And hematocrit will be increased because of concentration in the blood. On the other hand, if you will examine the patient who is hypervolemic, the JVP will be increased, blood pressure can be normal to increased, auscultation of the heart can lead to the production of the third heart sound, which is basically due to volume overload. Maybe the patient have pulmonary edema, and that will lead to inspiratory crackles. Skin turgor can be reduced, or sorry, can be increased or can be normal. Edema may be present. Urine output can be variable depending on the clinical scenario. Body weight will be increased and serum protein and hematocrit will be decreased, of course, due to dilutional effect. So these are all the things which will be there, right? Now, if you have seen this one, in the next lecture, in the next week, what we are going to discuss, we are going to discuss different type of IV fluids which are available, right? We will discuss what is crystalloids, what is colloids, what are the blood products, Here there is a overview of these things. If you can see, like they name what kind of intravenous fluids are there. They're like, this is about human plasma. This is 0.9% saline, or which is also called as normal saline. This is 4% dextrose with half normal saline. Okay, sorry, 4% dextrose with double normal saline, double strength. Okay. Um, this one is Hartmann's or Ringer lactate solution. This is 4% gelatin. This is 5% albumin. And if you can see over here, this is the normal osmolality of the human plasma: sodium, potassium, calcium, magnesium, chloride, lactate, and bicarbonate. And of course, like next week when we'll discuss these things in detail, you would understand this is what is present in the new normal human plasma, what is the content in normal cell line, what is the content in this one, what are the contents in Hartmann or Ringer lactate, in gelatin, in albumin. Of course, what are the uses of that? Okay, and how we are going, how we manage these things. We are going to discuss all these things in the next lecture, with the usages of the solutions, how, what are the places when we can use this, when we can use this, what is the function of this, what are the best situations when we can give this. Okay, all these things we are going to discuss in the next lecture. So and of course, like all these things are very important from surgical point of view. So now, again, I would like to tell you that it's better to go through uh, the basics, okay? Because if you know the basics, it will be easy for you to understand these things. If you don't know the basics, of course, you will stay confused because you don't have any idea. If you have time, go and read edema, go and read the normal body fluid compartments, go and read about the acid-base balance, also read about the electrolytes, okay? Because if you will see, like all these fluids have electrolytes, okay? So of course, like we have the daily requirements. We for example, uh, we need around 50 to 90 millimole per day of sodium, 50 millimole per day of potassium, 5 millimole per day of calcium, 1 millimole per day of magnesium. Okay, so of course, like we need all these things. Okay, we need all these uh, electrolytes because we lose these electrolytes on daily basis. So of course we must replace them uh, every day. Okay, so very important to remember like all these things. And of course, like whenever we are dealing with any patient, we always take a proper history. We do a physical examination. I show you this one. We check their pulse, we check their blood pressure, we check their sometimes CVP pressure, like central venous pressure. In the hospitals, they put the drains, they put the patient Foley's catheter, they attach with the urinary bag. So they are also checking the peripheries of the patient, the skin turgor, the urine output. Okay, and we keep on doing like electrolyte levels on daily basis, on 6 hourly basis, depending on like what the patient need. And depending on that, of course, we decide, depending on the clinical history, depending on the sign and symptoms, if the patient have vomiting, if the patient have diarrhea, if the patient have burns, all these things. So a lot of factors are there. On that, we decide what kind of fluid can be best for this patient. Okay, and then they choose, they estimate the amount of blood loss, the amount of volume loss, and then they make the decision what could be the best replacement fluid and how much should be given and how much electrolyte should be replaced, or what can be the best plan of action for certain patients. Okay, So of course, like you, when you will go through all these things, you would understand. So thank you so much for listening. And next week I'm going to talk about the next part for this lecture. Till then, goodbye.